Welcome. In this session, we'll be discussing about gonioscopy. In the previous session, we discussed about the anterior segment findings on the slit lamp in a glaucoma patient, and in the next session, we'll discuss how to examine the optic nerve head in a glaucoma patient. Gonioscopy is the assessment of the structures of the anterior chamber angle. This photograph shows the structure in a normal anterior chamber angle. This arrow points towards the ciliary body band. This arrow points towards the scleral spur. This arrow points towards the trabecular meshwork, and this arrow points towards the Schwall baseline. We'll discuss how to identify these structures on gonioscopy further in this session. Normally, light reflected from the angle structures undergo total internal reflection at the tear-air interface and cannot escape from the eye, preventing direct visualization of the angle. To eliminate this air-tear interface, a gonio lens is used with a coupling fluid between the gonio lens and the cornea. Gonioscopy can be performed in two ways: direct gonioscopy and indirect gonioscopy. In direct gonioscopy, the observer looks in the direction towards the quadrant of the angle being examined, and direct gonioscopy gives a direct non-reflected image, and so direct gonioscopy is used in angle surgery. Direct gonioscopy is usually done with the patient in the supine position, and for illumination and visualization the operating microscope is used. The direct gonio lenses commonly used include the Kep's lens and the Swan-Jacob lens. The Swan-Jacob lens has a handle to allow for adjustments during surgery. In indirect gonioscopy, the observer is looking in a direction opposite to the quadrant of the angle being examined, and in indirect gonioscopy a reflected image from a mirror is seen, and the angle of inclination of the mirror is described as the angle the mirror subtends with the surface of the gonio lens towards the observer. And that the indirect gonioscopy lenses have a mirror is very important to remember. The left quadrant of the anterior chamber angle is seen reflected from the mirror in the gonio lens on the right side of the patient. But as we will be seeing, right-left orientation with the horizontal mirrors and up-down orientation with the vertical mirrors is not inverted. Unlike direct gonioscopy, indirect gonioscopy is done with the patient in the erect position, and for illumination and visualization the slit lamp is used. And in indirect gonioscopy, the anterior chamber angle appears slightly shallower than with direct gonioscopy. Indirect gonioscopy can be done either with the Goldmann lens or with the 4-mirror lens. With the Goldmann 3-mirror or single mirror lens, only one mirror provides view of the corresponding opposite quadrant of the anterior chamber angle, so the lens needs to be rotated to visualize the angle all around. And the diameter of the contact surface of the Goldmann lens is larger than the diameter of the cornea. So pressure on the lens presses on the sclera, narrowing the angle, and thus pressure on the gonio lens should be avoided while performing gonioscopy. The contact surface of the Goldmann lens has a smaller radius of curvature as compared to the cornea, and thus requires viscoelastic for coupling. However, the Goldmann lens is said to provide the best view of the angle. In this photograph, we see a 3-mirror Goldmann lens. The Goldmann 3-mirror lens has a central lens and 3 mirrors. The central lens gives an erect view of the posterior 30 degrees of the retina. The equatorial mirror is the largest, is rectangular in shape and is inclined at 73 degrees, and it is used to visualize the retina from 30 degrees to the equator. The peripheral mirror is square-shaped and is inclined at 67 degrees and is used to visualize the retina from the equator to the ora serrata. The gonioscopy mirror is smallest and is dome-shaped or semicircular, and in the Goldmann 3-mirror lens is inclined at 59 degrees, and in the Goldmann single mirror lens is inclined at 62 degrees. And it is used to visualize the anterior chamber angle. So when doing gonioscopy with the Goldmann 3-mirror lens, it is important to remember that the smallest semicircular lens is the one to be used. Indirect gonioscopy can also be done with the 4-mirror gonio lenses as shown here in this photograph. And among the 4-mirror gonio lenses, we have the Poschner as shown here in this photograph and which has a handle, the Sussman as shown here in this photograph, and the Zeiss as shown here in this photograph which has an optional handle. Unlike the Goldmann lens, each of the 4 mirrors of the 4-mirror gonio lenses provide view of the corresponding opposite quadrants of the anterior chamber angle. So 4-mirror gonio lenses do not require rotation to visualize the entire anterior chamber angle. And unlike the Goldmann lens, whose contact surface radius of curvature is smaller than the radius of curvature of the cornea, the contact surface of the 4-mirror lenses have almost the same radius of curvature as that of the cornea, and so they do not require viscoelastic for coupling, and patients' own tears or normal saline suffice as the coupling agent between the contact surface of the 4-mirror gonio lenses and the cornea. Also, unlike the Goldmann lens, whose contact surface diameter is larger than the diameter of the cornea, the diameter of the contact surface of the 4-mirror gonio lenses are smaller than the diameter of the cornea, and so pressure on a 4-mirror lens presses on the cornea, increasing pressure in the aqueous, thus tending to open the angle. This is unlike the Goldmann lens, which when pushed towards the eye presses on the sclera instead of the cornea, thus tending to narrow the angle instead of opening it. However, like as with the Goldmann lens, pressure should not be applied on the 4-mirror lenses also when determining the native status of the anterior chamber angle, and excessive pressure on the gonio lens can be detected by formation of Descemet's folds in the cornea. However, there is a specific use of 4-mirror gonio lenses which involves pushing the gonio lens towards the eye, and this is called dynamic gonioscopy, which is very important to remember. Dynamic gonioscopy can be done only with the 4-mirror gonio lenses because, as we have discussed, when we push these 4-mirror gonio lenses towards the eye, these gonio lenses press on the cornea, displacing the aqueous, tending to open the anterior chamber angle. Dynamic gonioscopy cannot be done with the Goldmann lens because on pushing the Goldmann lens towards the eye, the Goldmann lens presses on the sclera and does not displace the aqueous. During gonioscopy, when we find there is contact of a portion of the peripheral iris with the angle, we can employ dynamic gonioscopy to differentiate between appositional and synechial angle closure, and this is very important to remember. In appositional angle closure, there is only contact between the peripheral iris and the angle, and on application of pressure on the 4-mirror gonio lens, the increased pressure in the aqueous pushes the peripheral iris posteriorly and the angle opens up. But in synechial angle closure, there is an actual adhesion between the peripheral iris and the angle, and even after application of pressure on the 4-mirror gonio lens, pushing the cornea and displacing the aqueous, the adhesion is not released and the peripheral iris continues to remain in contact with the angle. Dynamic gonioscopy can also differentiate open but narrow angle from partial closure of angle, as we will discuss in a subsequent session. So this photograph shows contact between a segment of the peripheral iris and the angle, and this photograph of the same eye demonstrates that on application of pressure with a Sussman lens, which is a 4-mirror gonio lens, the angle opens up in that area as the peripheral iris is pushed posteriorly by the displaced aqueous. However, this does not happen when pressure is applied with Goldmann lens and the contact between the peripheral iris and the angle persists. Indirect gonioscopy, both with the Goldmann lens and with the 4-mirror gonio lenses, start with topical anesthesia and application of coupling fluid if required on the contact surface of the gonio lens. The patient is asked to look upwards while the lower eyelid of the patient is gently pulled forwards and downwards, and the lower rim of the gonio lens is inserted into the lower fornix. The patient is then asked to look straight. the mirror of the gonio lens opposite to the quadrant of the anterior chamber angle to be examined is illuminated. However, the illumination of the eye should be minimized because excessive illumination can constrict the pupil and artificially widen the anterior chamber angle. So the room illumination needs to be dimmed so that the amount of light entering the fellow eye is also minimized, and a short thin slit beam of light is used to examine the eye. This photograph shows that the angle appears open with bright light, but when the illumination is reduced, the angle appears to narrow. For a better view of a quadrant of the anterior chamber angle, the patient is asked to look in a direction opposite to the quadrant being examined, that is, towards the mirror with which that quadrant is being examined, and the gonio lens can be tilted towards the quadrant being examined. This photograph shows that the quadrant of an angle which appears to be narrow becomes wider in appearance when the gonio lens is tilted towards that quadrant. When we get the view of the angle during indirect gonioscopy, the first thing to do is detect the landmarks, and the important landmarks to find is the Schwalbe line and the scleral spur. The Schwalbe line is detected by the corneal wedge technique, and the scleral spur is the pale zone between the ciliary body band and the trabecular meshwork. So this photograph shows all the structures which can be seen in the anterior chamber angle. Starting from the peripheral iris posteriorly, as we move anteriorly, we will find the ciliary body band darkly pigmented, a lighter band the scleral spur between the ciliary body and the trabecular meshwork. The posterior part of the trabecular meshwork appears to be more pigmented than the anterior part of the trabecular meshwork, and anterior to the anterior part of the trabecular meshwork we have the Schwalbe's line. The parallel pipe technique to locate the Schwalbe's line is to project a thin slit beam to identify the two reflections, one from the external surface of the cornea and the corneoscleral junction, and one from the endothelial surface of the cornea. The point where these two reflections meet is the Schwalbe's line. And the inferior quadrant of the angle usually being the widest quadrant of the angle, it is easiest to identify the landmarks in this portion of the angle. Width of the angle depends on the iris, its insertion on the anterior face of the ciliary body, the curvature of its anterior surface, and the prominence of its peripheral roll adjacent to the angle. An angle closure is said to be present when view of the trabecular meshwork is partially or completely obstructed by the peripheral iris, and this is very important to remember. And following grading, any pathological changes in the anterior chamber angle are noted. To describe the width of the angle, a standard grading system can be used or the angle features can be drawn. If a grading system is used, the name of the grading system should be mentioned. And for each of the two eyes, each of the four quadrants is separately graded. We'll discuss the three most common grading systems: Schaffer's, Scheie's, and Spaeth's. In the Schaffer's grading system, the angle between the peripheral iris and the inner surface of the trabecular meshwork is used to grade the angle. When the angle between these two lines is 45 degrees as shown here in this diagram, the anterior chamber angle is graded as 4, and when the angle between these two lines is between 20 and 45 degrees, the anterior chamber angle is graded as 3. In grade 4 and grade 3 anterior chamber angles, angle closure is said to be not possible. When the angle between these two lines is 20 degrees, the angle is graded as 2 and angle closure is said to be possible. And when the angle between these two lines is 10 degrees, the angle is graded to be 1 and angle closure is said to be probable. When the angle between the two lines is less than 10 degrees, the angle is graded as slit and angle closure is said to be very likely. When the peripheral iris is opposed to the trabecular meshwork, the angle between the lines is 0, the anterior chamber angle is graded as 0 and angle closure is already present. In the Shaffer grading system, it is important to note that grade 4 represents the widest angle and there is a slit grade between grade 0 and grade 1. The Scheie grading system is based on the posterior-most angled structure visible during gonioscopy. In the wide grade, all structures are visible including the angled recess between the iris and the ciliary body band. In grade 1, the ciliary body band is visible but the angled recess is not visible. In grade 2, the ciliary body band is not visible and the scleral spur is the posterior-most angled structure visible. In grade 3, the ciliary body, scleral spur and posterior portion of the trabecular meshwork is not visible and the anterior portion of the trabecular meshwork is the posterior-most angled structure to be visible. And in grade 4, ciliary body, scleral spur and trabecular meshwork are not visible and only Schwalbe's line is visible on gonioscopy. We note here that in contrast to Schaffer's grading system, the grades in the Scheie grading system is given in Roman numerals and grade 4 represents narrow angle in contrast to the Schaffer's grading system where grade 4 represents open angle. Spaeth's grading system takes into account 4 parameters: the apparent insertion of the peripheral iris, the curvature of the anterior surface of the iris, the angle between the peripheral iris and the trabecular meshwork, and pigmentation of the posterior portion of the trabecular meshwork. The insertion of peripheral iris is graded as A when it appears to insert anterior to the Schwalbe's line, as B when it appears to insert posterior to the Schwalbe's line, as C when it appears to insert behind the scleral spur and so the scleral spur is visible, as D when the ciliary body is visible, and as E when at least 1 mm width of the ciliary body is visible. The configuration of the peripheral iris is classified as B when it bows anteriorly, as P when the configuration is that of a Plato iris, as F when it is flat, and as C when it is concave, also called queer in the Spaeth's grading system. Angle between the line tangential to the iris 1/3 of its distance from the iris root to the pupil and the line along the aqueous surface of the trabecular meshwork is also considered in the Spaeth's grading system, and the angle is graded between 0 and 50 degrees at intervals of 10 degrees. Pigmentation of the posterior trabecular meshwork at 12 o'clock position is also considered in the Spaeth's grading system. There is no single universally accepted definition for occludable angle, which is an indication for laser peripheral iridotomy, and occludable angles have been variously defined as narrow angles with peripheral anterior synechia in the Spaeth system as iris insertion grades A or B, iridotrabecular angle of 10 to 20 degrees or less, and forward bowing of the iris in the Shaffer system as grade 2 or less, or iridotrabecular angle of 20 degrees or less, and in the Scheie system as grade 3 or 4 for more than 90 degrees around the angle circumference, or in other words, the posterior trabecular meshwork being visible for less than 90 degrees around the angle circumference. Now we come to some findings on gonioscopy. Blood in the Schlem's canal is normally not found, but can be present in elevated episcleral venous pressure, hypotony, but most commonly due to excessive pressure on the episcleral veins by a gonio lens. Blood in Schlem's canal, if found, lies peripheral to the anterior less pigmented portion of the trabecular meshwork and is difficult to detect in pigmented eyes. Normal blood vessels are either oriented radially on the iris or circumferentially along the ciliary body band central to the scleral spur, and these include the radial iris vessels, portions of the major arterial circle, and vertical branches of the anterior ciliary arteries. Abnormal blood vessels found in angle neovascularization cross anteriorly across the scleral spur and arborize over the trabecular meshwork. And this is very important to remember. So this photograph shows angle neovascularization. We need to differentiate between iris processes and peripheral anterior synechia. Iris processes follow the contour of the angle and they are thin and lacy, with angle structures being visible between them, and they do not extend up to the trabecular meshwork. Peripheral anterior synechia, as seen in this photograph, are broader, sheet-like, and obscures angle structures through them. And peripheral anterior synechia can extend anterior to the scleral spur as far as to the posterior surface of the cornea. Pigmentation of the angle is more common in eyes with darkly pigmented iris, and pigmentation increases with age. Pigmentation can be segmental and is usually more prominent in the inferior quadrant of the angle. Heavy angle pigmentation can be found in pigment dispersion syndrome, pseudoexfoliation syndrome, iris chafing by a malpositioned intraocular lens, trauma, inflammation, tumors, and angle closure. This photograph is of an eye with pigment dispersion syndrome demonstrating heavy pigmentation in the anterior chamber angle. In pigment dispersion syndrome, pigment release from the posterior iris ultimately ceases over time, following which pigmentation of the angle actually decreases, and the decrease of pigmentation occurs more rapidly in the inferior quadrant of the angle. And so at this stage, superior quadrant may actually appear to be more pigmented, unlike what is found normally, and sometimes this more pigmented superior quadrant may be the only remaining sign of previous pigment dispersion. In pseudoexfoliation syndrome, there can be a linear pigmentation anterior to the Schwalbe's line, called the Sampaoli's line. Gonioscopy may reveal evidence of blunt trauma such as angle recession, iridodialysis, cyclodialysis, and tears in the trabecular meshwork itself. In angle recession, there is a tear between the longitudinal and circular fibers of the ciliary body as shown in this diagram. The longitudinal fibers of the ciliary body are located more peripherally, and the circular muscles of the ciliary body are located more centrally, and the tear in angle recession occurs between these two subgroups of ciliary muscles. In angle recession, we will find a wide ciliary body band in the region of the angle damage, and there will be a characteristic variability of the width of the ciliary body band and consequently the depth of the angle between different quadrants of the same eye and between similar quadrants of the two eyes. So the ciliary body band appears wider in the region of angle recession as compared to the width of the ciliary body band in the non-injured area. Torn iris processes and increased prominence of the scleral spur can also be found. This photograph shows a patient with angle recession with a wide ciliary body band and torn iris processes. Iridodialysis is tearing of the iris from the ciliary body at the iris root, and this diagram represents the gonioscopic appearance in a patient with iridodialysis. In cyclodialysis, there is detachment of the ciliary body from the scleral spur with the formation of a gap between the sclera and the ciliary body, and this diagram represents the finding in cyclodialysis with detachment of the ciliary body band from the sclera with visibility of a larger area of the sclera. However, a very small gap may not be detected on gonioscopy and may require ultrasound biomicroscopy to be identified. A tear may occur in the trabecular meshwork itself, with this diagram representing the appearance of the tear in the trabecular meshwork on gonioscopy. Other signs which can be detected on gonioscopy include inflammatory deposits as seen here in this photograph, minimal hypopyon or hyphema in the inferior sector of the angle which may be missed on standard slit lamp examination of the anterior segment, foreign body, tumors, zonular dehiscence, anterior rotation of ciliary processes, these two findings being detected on gonioscopy after pupillary dilatation, retained lens matter following cataract surgery, particularly in the inferior sector of the angle, displaced or iris perforating IOL haptics, inner opening of trabeculectomy, goniotomy or trabeculotomy clefts, and surgical devices positioned in the angle for treatment of glaucoma. So following routine slit lamp examination, intraocular pressure measurement and gonioscopy, the pupils are dilated for fundus examination, which we will be discussing in the next session. To recap the salient points, gonioscopy is the assessment of the structural status of the anterior chamber angle. A gonio lens is required to eliminate the total internal reflection from the tear-air interface of the rays reflected from the angle. Direct gonioscopy is used during angle surgery. Two examples of direct gonio lenses are Kep's and Swan-Jacob lens. Indirect gonioscopy is used during slit lamp examination. Indirect gonioscopy can be done with the Goldmann 3-mirror lens or the 4-mirror gonio lenses such as the Posner, Sussman and Zeiss. With the Goldmann lens, only one of the mirrors, the smallest semicircular mirror, gives adequate view of the angle, so the Goldmann lens requires rotation to examine all 4 quadrants of the angle, and the Goldmann lens requires viscoelastic to couple the lens to the cornea. Pressure on the Goldmann lens compresses the sclera and narrows the angle. With 4-mirror lenses, all 4 mirrors give adequate view of the angle, and so these lenses do not require rotation to examine all 4 quadrants of the angle, and also do not require viscoelastic to couple the lens to the cornea. These lenses can be coupled by patient's tears and normal saline. Pressure on a 4-mirror lens compresses the cornea and widens the angle, and can be used for indentation gonioscopy, which differentiates between synechial and appositional angle closure. View of the angle is best with Goldmann lens, and it can be improved further by asking the patient to look towards the mirror being viewed to examine the opposite quadrant of the angle, or by tilting the gonio lens towards the quadrant of the angle being viewed. Gonioscopy should be done with minimal room and slit illumination so as not to artificially constrict the pupil and widen the angle. The landmarks which help to recognize the structures in the angle are the Schwalbe's line and the scleral spur. The Schwalbe's line can be identified as the meeting point of the 2 reflexes from the endothelial and the epithelial surfaces of the cornea. In a wide open normal angle, the structures which can be identified in sequence from anterior to posterior are the Schwalbe's line, anterior and posterior portions of the trabecular meshwork, scleral spur and ciliary body band. The width of the angle depends on the iris, its level of attachment to the anterior face of the ciliary body, the curvature of its anterior surface, and the prominence of its peripheral roll. An angle is said to be narrow when view of the trabecular meshwork is partially or fully obstructed by the peripheral iris. There are multiple grading systems for describing the width of the angle. The Shaffer grading system is based on the angulation between the peripheral iris and the aqueous surface of the trabecular meshwork. The Shaffer's grading system also mentions the likelihood of closure of an angle of a specific grade. Scheie's grading system is based on the most posterior angle structure visible just in front of the peripheral iris. Spaeth's grading system is based on 4 parameters: the apparent level of insertion of the iris, the angulation between the peripheral iris and the surface of the trabecular meshwork, the curvature of the anterior surface of the iris, and pigmentation of the posterior trabecular meshwork. Thank you for listening.